of Standing Order 45-2 for the remainder of today's sitting.
The question is that Standing Order 45-2 be suspended for the remainder of today's sitting. Will all honorable senators in favor please say aye? Those against please say no. The the ayes have it. The standing order is therefore suspended for the remainder of today's sitting.
Introduction of bills.
Senator Cummings.
Mr. President, I beg to move the introduction of the Queen Elizabeth Hospital Amendment Bill 2024 and to move that this bill be read a first time.
The question is that this bill be read the first time. Will all honorable senators in favor please say aye? Aye. Those against please say no. With the ayes have it.
Public business, sir.
Public business is now the order of the day.
Order number 5, sir. In the name of Senior Minister, Senator the Most Honorable Mr. Walker, Minister of Health and Wellness, to move the second reading of the Queen Elizabeth Hospital Amendment Bill 2024.
Senator the Most Honorable Mr. Walcott.
Good morning, Mr. President. Mr. President, as I rise this morning to lead off debate on this amendment of the QEH Hospital Act, I'm almost tempted to say such a simple amendment. In ideal conditions, one would deal with this in about 5 minutes, and we'll be on to the next item. But the times we're living right now are not conducive to that. I mean, unfortunately, the QH has become very popular these days. Extremely popular on the call-in programs, extremely popular on the social media, and of course, very popular among the 3 shadow ministers who are all members of the DLP. I'm never sure which one isn't. Mr. President, you would have been aware of one of them who was all over the social media this past weekend, giving entertainment to all and sundry. And in regards to his queries about health, I would follow his General Secretary. However, the matter of criticism, the QH, the matter of criticism of the hospital is to be expected, Mr. President, because of the nature of the services which tertiary care institutions and general hospitals are expected to provide for the persons and citizens of a country who need medical assistance, medical attention. However, Mr. President, the complaints are regrettable. They are numerous and vary from waiting times at the accident and emergency department to the time it takes to see a doctor in the clinics. And indeed, my colleague on the other side who is looking at me would know about the matters of the vexing and frustrating issue of persons going for elective surgeries and having them being postponed. Not to say that the honorable member is responsible for this. The Department of ENT perhaps has a record of about 80% of its cases that are on any list that are done. So some of these criticisms, however, are justified. Some are inexcusable, and most of them are unfortunate. But one thing is certain, Mr. President, that they all have to be addressed. They have to be addressed, some with a sense of urgency, and there are others that require procurement of equipment, capital works that will obviously take a long time. But Mr. President, I'm going to be bold this morning, that in spite of all the criticisms and the complaints, that hospital, the Queen Elizabeth Hospital, or hospital, because sometimes when I listen to the criticisms, we get the impression that you were somewhere else, and this is the hospital that you can just discard. At the end of the day, it is our only hospital. or main hospital. And they do very good work in that institution every day, contrary to popular belief. Very good work. And I must commend the hard-working staff. The majority work hard and are dedicated and committed. The medical staff, the nursing staff, the paramedical staff, the physiotherapists, the ancillary staff, they all work extremely hard to ensure that health of Barbadians is maintained in that institution. So it was not a long time ago when in Barbados, the members of staff of our hospital were praised and commended for the remarkable work they did during the COVID pandemic. At that time, most persons in here were working for home or just at home. These individuals, regrettably, some of these same individuals who were working tirelessly to ensure that the pain and suffering and deaths that we saw portrayed on televisions every night across the globe would not be occurring here. Yet, several of those same persons who worked tirelessly now bear the brunt of criticism and are worse than worse. Sir, this is the same QH that served us then, and has served this country for almost 60 years. In November, it will be celebrating 60 years as our institution. It has shortcomings. There's no denying that. There are shortcomings. And all of these shortcomings have to be addressed. And it is the role of this government and the intention to address all of them. I can't predict the future. I don't know how long I will be here. But it is the intention of this government to ensure that all of those shortcomings identified currently at the QH are addressed. Obviously, all will not be addressed at one and the same time. Mr. President, but I know you believe me. You know the bond that exists between me and the Queen Elizabeth Hospital. There's no denying that. I was a student there. I was an intern there. I know about the long hours. I was a registrar there. I did most of my surgical training there. I was a consultant there. I was a lecturer in surgery there. And incidentally, Mr. President, I have also been hospitalized there and had surgery there in the past. So you know the bond that is attached to me and linked to me in the QH. When I say I want to make the QH a better place to be, a place that Barbadians would talk about daily in a positive way, that is how I feel. Mr. President, the QH didn't get there where it is overnight. And it will not get out of it overnight. But I sincerely hope that by doing this simple amendment, it signals the beginning of a process to resuscitate the QEH. Mr. President, I need to give some historical context to the matter, this simple matter before us. The matter of public complaints and criticism of the Queen Elizabeth Hospital about treatment received there has dogged and bothered both DLP and BLP administrations almost 4 decades. Thank you. During that time, even further back, but in that 40 years, there have been 10 ministers of health and a minister of state. Mr. President, when I counted 10, I included myself twice. I'm a glutton for punishment. There have been 10 ministers, and all of them, everyone, has experienced complaints and criticisms about the QH. Hence, in 1960, as it was then Minister Tate, requested a study titled The Rationalization of Health Care within the QH. 1990 days. In 1998, in the face of continued complaints and concerns, our administration established the Haynes Commission of Inquiry into the QH to review deficiencies and to make specific recommendations to improve the governance operations of the institution. And this was the famous Haynes Commission, made up of several prominent Barbadians at that time. The final document, I believe, is a document of this honorable chamber, titled The Report of the Advisory Commission of Inquiry into the QH. And that report spoke about the need for a change in the governance structure at that institution and recommended the need for a board of management. I should add that historically, when you review the QH, there was a bill for the establishment of a board of management as far back as 1966, but it was never proclaimed. The minister at the time was Dr. Ramsey Scadder, and the chairman to be, which never occurred, was one Carolyn Barr, who was then the wife of the Prime Minister in Barbados. So it recommended this board of management, which it said would give greater autonomy to the QH, would make it become more efficient, and give it a level of accountability as an institution in its own right. It went on to recommend that the composition of the board should encompass views and opinions of the broader community. I came up with this remarkable equation, where it would be a board comprised of 10 persons, only 3 of whom would be selected by the minister. The chairman, the deputy chair, and 1 other. That was the writ of the minister. The other members were drawn from representatives of these entities, the Barbados Registered Nurses Association at the time, now called the BNA, the Barbados Association of Medical Practitioners, CTUSAB, the Barbados Association of Retired Persons, the Barbados Christian Council, the Barbados Chamber of Commerce, and the University of the West Indies. That was the first time anywhere in the Caribbean where an entity like that had been established, where the full power resided outside of the office of the minister. I happened to be the minister, and a lot of persons thought that it was not the right thing to do. Suffice it to say, the government changed in 2008, and the immediate amendment done by the new government was to remove that and have a situation where the minister would choose to elect and empower all of the members of the QEH board. And that has remained until now. But in spite of this, the board, and going through the change of government through the ensuing years, the QEH has continued to experience challenges. And consequently, in 2019, some honorable members will remember, a decision was made that the hospital's governance and management structures should be re-engineered to improve governance and efficiency. And in this very chamber, that bill was passed. And this entailed the abolition of the post of Chief Executive Officer and the creation of the post of Executive Chairman. Mr. President, this worked very well during COVID, when decisions had to be made quickly and decisive action taken. And in this regard, at this time, the former executive chair has to be commended for her outstanding leadership and for the remarkable job she did in marshalling her troops, her directors, to face the Herculean task of COVID across the island. However, post-COVID, the process has not worked as efficiently as anticipated. A decision was made to revert to the original governance structure as we embark on a new strategy to tackle these problems, hence why we are here today. Mr. President, the ex-chair had indicated at the end of her contract in December 2022, she would not be renewing it, that she would be moving on to a new career path, and I think some members in this chamber are familiar with the new path that she's to embark on. However, she graciously agreed to extend her stay with us until June last year to help the QH prepare for the transition. And I dare say I know that she was involved in the discussions about the parameters and the requirements for a new CEO. She was up in that discussion and part of the process in preparing the questions and whatever. And I must thank her again for her unswerving commitment to improving the QH while she was there, and I'm certainly very confident that she will do exceedingly well in her new assignment. Mr. President, the process for the recruitment of the new CEO has obviously gone along in parallel to all of this. A committee was established by the board. It's been the board's process, the selection. I'm not going to give a presentation this morning on what happened in there, but I can tell you, suffice it to say, because there are always inquisitive persons who want to write stories, that 84 persons applied. 84 persons applied for the post of CEO of the Queen Elizabeth Hospital. The news has been out in terms of the selection, but what I would say for those who ask about Barbadians and non-Barbadians, 2 Barbadians applied for that post. 2 out of 84. And both of them were deemed not suitably qualified, and they certainly didn't have the experience. The board went through its process, the committee of the board, 84, they were down to 12, and then I believe they had selected 6 to be interviewed, but then 1 person dropped out, and they interviewed 5, and they have come to a selection. They've made a selection. So that process is on track. Over the past, I assumed the ministry in November 2022. At that time, there was a Minister of State assigned to the Queen Elizabeth Hospital and to chronic diseases. And some of you would have noticed me involved, but not openly out there speaking about the QH. The Minister of State had responsibility for that. Now, I'm really involved in the QH matters. We've had meetings with the QH directors, with the QH management. We've had internal meetings. We've had meetings with the Ministry of the Public Service. Of course, we've had meetings with the board on how we go about addressing these myriad issues that are affecting the QH and the delivery of health care for that institution. We've been as far as having a number of meetings with the Prime Minister of Barbados, because if the QEH is to really move the resources, both human, financial, and otherwise, we need the buy-in and the support of the Prime Minister. And we've been having several meetings, and we've made substantial progress as it relates to the needs of the QEH. So we mean business, and I'm sure that you've heard the Honourable Prime Minister speaking to some of the things that are planned for the QEH. But for the benefit of colleagues in this chamber, and especially for those on the other side, so that they can save some of their saliva and don't attempt to go down a litany of woes in this chamber this morning, not trying to pigeonhole anyone into there. Certainly not my colleague, Senator Rogers, not at all. I know that he tells it from the pulpit, he tells it from the heart, he tells it from the Bible. So I know I can't control him. But let us start with the plans where we're going with the accident and emergency department. The main issues identified are the waiting times. Oftentimes, the waiting time has to do with space, because it's congested, there's nowhere to put people. They're waiting to see doctors who are coming, who they've been referred to, who are in the medical wards especially. First of all, the QH is going through finalizing the phase 3, the completion of the total expansion. The space is expected to be double what it is now. So out there 19 cubicle spaces, they're expected to be at least 38 when it is completed, to provide more space for patients. Clearly, we expect less congestion. There were issues about the patient flow in the QH, the triage system, then you go here, then you come here. These things are going to be looked at again. We're trying to look into implement a system, because oftentimes, in spite of the advice about using polyclinics, persons still go to the A&E department with what we call Category 5, matters that can be dealt with in polyclinics or elsewhere and don't need to be an accident and emergency. And we plan to reintroduce something that existed certainly back in my time, decades ago, which was called See and Treat, where adjacent to the triage, you would have a doctor there to see basic things that need to be seen and just dealt with and not clog up the department. We often hear of complaints about people waiting for hours to get a CT scan. And this is especially very important because in the QH we had what we call a stroke unit. And we have made these very wonderful plans about implementing early management of strokes early on, diagnosis, CT scan, determine what type of bleed it is in the brain, and if there were candidates for what we call fibrinolytics to dissolve the clots, to put it simply. Oftentimes, persons came to A&E within that 4-hour window. You expect to have treatment within 4 hours, the first 4 hours of that stroke. But you need a CAT scan first to ascertain that you don't make a bad situation worse. And oftentimes the delay at A&E has been, regrettably, trying to get persons to the X-ray unit in another part of the hospital, trying to get orderlies, nurses, trolleys to get them there. The plan in the expanded A&E department is now to install a CT scan there, a new CT scan, so that persons who need to have an urgent CT scan, they don't have to be taken up the corridor. They will have that in A&E to expedite the processes and try again to improve the patient outcome if they're having a stroke. The matter of a chest pain clinic. I know the honorable member on the other side has heard a lot about this chest pain clinic. It was supposed to be implemented for a number of years. Government has agreed to the positions required. The additional consultants, the additional nurses, the additional ECG people and the cardiac people to assist. The paramedics in the ambulances were trained. So you're looking at picking up heart attacks early, recognizing the trend, recognizing the ECG changes, and trying to implement treatment on the road, so to speak, stabilize the person before they get to A&E, where you will have a designated area called the chest pain clinic. And the plan is that this goes down to the cardiac theaters where persons can have the intravenous invasive strap done as an emergency as needed. So you're trying to take it to a different level in terms of care and managing strokes and managing heart attacks. So this is something now to be rolled out. The good news also is that there have been complaints about the need for more staff, and there's agreement that A&E will be provided with additional staff, not only medical staff, but all levels, nurses, orderlies, and obviously for the X-ray facilities, we will have the radiographer station there. But I should caution that when we speak of doctors, more doctors at A&E, we are speaking about doctors who are already trained in accident and emergency. The plan is, it is a training hospital. We have registrars who are being trained, but the plan is not to increase the number of registrar posts to allow further training, because I think members would appreciate that if you have a registrar in training in emergency medicine, in training, and he or she sees someone, they can't make a definitive diagnosis. They still have to have that person trained in A&E to come and sign off or to agree with the diagnosis, and that takes time. The plan in getting these additional doctors is to get doctors that can hit the ground running in accident and emergency and see patients and start to implement treatment. So the staff is coming, and that has been a long time. We plan to look at the whole triage process again, and of course, the need for more and new equipment. We've expanded the department. We obviously need new and more equipment, and this is being ordered. A&E is also faced with a vexing problem of overcrowding because of persons who are, as we categorize them, elderly for care. who essentially, and I think honorable members have heard this story, this is a sad story, repeatedly, where persons, elderly persons primarily, are brought to any department. They might be dehydrated, probably had respiratory tract infection. They're treated for it. And when it is time for them to be discharged, no one is able to take them home. There's no one there to look after them. And they came from homes usually, but this is an opportunity. This has been something that has bothered the QH for several decades. We introduced, I believe it was the honorable member on the other side who started the alternative care, the elderly program. On the other side, this side. The deputy president, who started, the distinguished member is just being elegant and demure. But she was the woman who started the alternative care, the elderly program. And it made a lot of sense. And it was expanded. The last time we were in government, it was accommodating 200 persons. Come back to it 15 years later, it has only 135 spaces. So we have decided that we need to get it back up. And it makes absolute sense. Rather than keeping persons in the geriatric hospital or the hospital, you try to get them into these alternative care accommodation. They are examined and they are visited and they have to be licensed and registered. And government pays for the accommodation of two categories of old persons in this: the ill ones who need nursing care, medicines, whatever, and those who are mobile, ambulant, and look after themselves. And we have found that it is much cheaper to keep them in those facilities than to keep them in the QH, where the average cost per patient is just over $1,000 per person per day, while you can have these persons in the alternative care program for less than roughly $100 a day. So it makes perfect sense. So we're trying, as I said, to increase the numbers again, 200, but it keeps increasing. You discharge persons, you get them into alternative care, you get them into the geriatric system today, and by weekend, you have an additional 20, 15 to be dealt with. It is a problem that we have engaged the Ministry of People's Employment. It is a societal problem. It is a behavioral problem. It is something that Barbadians as a people who are accustomed to looking after their elderly folk have suddenly lost interest in that, to put it in a simple form. So that is still a matter that we have to wrap our heads around. As related to the hospital, naturally, other departments in the hospital and their function can affect the accident and emergency department. We often hear that the bugbear is internal medicine, where patients are waiting for several hours to be reviewed by registrars or doctors coming who are on call in internal medicine. And we have agreed that they have made a request in terms of numbers of registrars, and their request will be granted. Having done that, we expect to see the concomitant improvement and reduction in the delays in seeing patients. We have making provisions for additional anesthetists, and again, anesthetists that can hit the ground running, because gone are the days, certainly in my time, 25, 30 years ago, probably 100 years ago, we did surgery, Mr. President, from 8 until 6, until the list was finished. The anesthetists came in. A lot of them were not from here, they were from the subcontinent, and they would come in the afternoon, and whatever was on that list, we did. If we went to 6, if we went to 7, the list of patients was to be done. These are different times. And we think that we need to get back to a situation where operating theaters function essentially from 8 until 7 or 8 at night. And to do that, we need additional nurses, we need additional anesthetists, and we need additional junior staff. And provision has been made for this. There have been concerns about pediatric surgery. And we've had some issues there, which we have addressed. We have addressed in one direction. We are seeking now to recruit a pediatric surgeon, believe it or not, in Barbados. And in the interim, there's a plan to bring a pediatric surgeon from Trinidad to fill the gap. ENT, they have been doing quite well, but they will get an additional staff member. There's need, obviously, with the issues of diabetes and kidney disease. We need additional help in nephrology, and there are plans to recruit additional nephrologists. We have one gastroenterologist at the hospital. There are about 5 in the private practice, I believe, 5. And for another place, not today, I'll be speaking about a launch of a colonic cancer screening program, where we are seeing rising numbers of colon cancer in Barbados. In terms of the death rate, is number 3 in Barbados, common to both men and women. And I think it is time for us to do some screening to try to pick up some of these cancers much earlier and treat it. And having said that, there's no sense screening if you don't have the gastroenterologist, the number that you need to do colonoscopies when they're needed. The plan is, globally, is to move away from a colonoscopy as the first step in screening. But there are other non-invasive tests that can be done early to pick up, which some of the patients can do at home, and to move in that direction. So we will be recruiting additional gastroenterologists. We will be obtaining additional scopes to do the work, and obviously we'll need additional nurses in this area. There's one area, there are 2 areas that I've left, and I've left them deliberately, Mr. President. But we are looking to recruit a rheumatologist. The one that we had resigned during the course of the year. And you would appreciate, Mr. President, where in our small societies we have one person trained in a specific area, and that person has a private practice and work obviously in the public service. And sometimes it becomes difficult depending on how busy one is in the more lucrative arm of your practice. And that can create a problem. There are also plans to get additional oncologists at the QEH. And this brings me to, I don't know about pet peeves, Mr. President, but there's some things that I just read and smile. Other people will probably use abusive language in dealing with them, but there's some things I just smile and ignore and act like my good friend, the General Secretary, and pay them no attention. 2, I've seen on a number of blogs and chats belonging to persons on the other side, not in here today, where they speak about Barbados and women and the incidence of breast cancer. And all of this flying and all of this, and you can't get a mammogram in the hospital. Mr. President, when I was last Minister of Health, we demitted office in January 2008. There was a functioning mammography unit at the Queen Elizabeth Hospital. It stopped functioning in 2009, July 2009. And I'm reading that this government is doing all this and you can't even get a mammogram at the QEH. There's always a time for politics, Mr. President. There's always a time for politics. But when it comes to healthcare, trying to play this political football game, when you know you're guilty of not providing the service, then we have a problem. The QH has a mammogram unit on order. The space for the mammogram is still there. It hasn't been used since 2009. I don't know who was the minister then. I don't think it is my good colleague, on the other side. I don't think it is any relative of his who was involved or who was the Minister of Health then. He knows that. I believe his relative came in 2013. There's the aside. Mr. President, the asides are bothering me, believe it or not. The other one is this matter of oncology treatment. And I read in January a whole back page, a story of persons in Barbados can't get cancer treatment. And some of them errant, obviously, writing about machine not working for over a year. Machine not working for over a year. And up to now, I hope that the honourable member from the other side of the opposition can help me, because it's been emanating from his side repeatedly. What is the name of this piece of equipment that has not been working for over a year in cancer, for cancer treatment? What is it? Because it is not the brachytherapy machine. It is not the one that a previous administration encouraged our national hero to purchase, the cobalt machine. So I don't know what it is. It is not the gamma camera. Not one of those pieces of equipment has been non-functional since the cyber attack. The cobalt machine and the gamma camera went down for 2 weeks, December, January 2022. Yet, I can read and hear extracts on the newspaper from persons from that side talking about cancer equipment not working for a year. Where is this cancer equipment, and what is the name of the piece of equipment? It can't be a linear accelerator. It can't be. Where the story said that you can't get this treatment, because the QH will be 60 years in November, and it has never had a linear accelerator. Never. And the honorable member knows that. Indeed, in 2007, I did a paper doing estimates. I took a paper to cabinet too before the estimates. And the Prime Minister at the time told me it was a very big desire. But at that point in time, not affordable. They were saying about 10 or 12 million back then. That was 2007. If you care so much about cancer patients and their treatment and lack of treatment, what did you do between 2008 and 2018 as regard these same cancer patients? What do you do? But come now to say it should happen yesterday. You were there for 10 years and did absolutely nothing. No mammograms, no linear accelerator, and come with a lot of false vanity and simple false emotion and passion and concern. But, as I said, we're going to procure a mammogram machine this year, and the government is making substantial progress towards obtaining a linear accelerator. We also will need to look at the oncology department in terms of its staffing. Meanwhile, persons are being sent to Colombia, and this has been going on since last year. Persons are being sent to Colombia who need radiation treatment and other treatment. There's a medical aid scheme within the budget of the QH, and it makes provision for this. And not only cancer treatment, it makes provision for other things not available in Barbados. And I believe over the past year, about 26 people have been sent to Colombia for their radiation treatment, paid for fully by the government, and incidentally, Mr. President, by a chaperone. By a chaperone. So you have a situation where you're paying $50-something thousand for a person, US. And you're then paying half of that, essentially, or a third of that, for a chaperone to go with them, to be given per diem for every day. Yet they're being covered by the government to the institution. And then I could read that the government is not providing the money for them. I believe, Mr. President, you would agree with me if I said that the cost of chaperones should be used to send additional patients who need it. So these are the sort of things and decisions that we will have to consider. Certainly with the acquisition of the linear accelerator, we will need to send them overseas for a variety of cancers. But we will also have to ensure, Mr. President, as an institution, that the use of the linear accelerator for private purposes, while it is in the hospital, the hospital has somewhere, and knowing and ascertaining that private services are paid for and not utilized like the work was done as in the days of the Haynes Commission of Inquiry, where the private work was being done, but the QVH was not benefiting. So those things will have to be looked at going forward. Mr. President, I'm sure the nurses will be delighted. They've heard the Prime Minister, but permission has been given for the QVH to recruit, hire an additional 60 nurses. We don't have them here. And clearly, there will have to be foreign recruitment. I believe they're looking at Ghana again, but they're also looking at Philippines, which where we obtained nurses from several years ago, and I dare say some of them are still here. There are a number of additional posts that my colleague next to me knows about in terms of the requests and the approvals. And then it brings me to CapEx. The hospital has been given a mandate and it's in the final stages of negotiations where a loan of $150 million, 130, will be borrowed by the QH. And the proceeds of the levy will be used to cover that cost. That $130 million will allow them to bring in replace equipment, bring new equipment, obtain an MRI for the first time. Because I also heard on the call-in program sometime back that people were waiting in the A&E for an MRI. QH has never had an MRI, so I don't know why they would be waiting in the A&E for an MRI. But these are the things, this is the times that we live in. And that $130 million will be used, as I said, to purchase equipment, replace equipment in the QEH. I mentioned the congestion, the elderly for care. Mr. President, there's also a matter, and if people were attentive and paying attention, as they do to the social media, they would have known and seen that 2 weeks ago, there was a request for information for the expansion of the QEH. That was in a newspaper about 3 weeks ago. And it was there to show. I said a request for information, Mr. President. I'm being very specific. It was there for persons who are interested in providing services for the expansion of the hospital. I'm hearing the honorable member say that he sent in information. He sent in a request. He sent in information.
Yes.
I don't know what he's doing with the ideas. It was supposed to be submitted by Mr. President. The ideas were supposed to be submitted by the 1st of March, so I don't know what he would be doing with his ideas on the pad in front of him. Suffice it to say that is a project. It speaks to expansion. It speaks to a new lab. It speaks to an oncology center. It speaks to a new administration. It speaks to space for clinics. And it speaks to a rehabilitation center. And it speaks to a bridge across the road linking to that. So this is what that was about. And Mr. President, I'm not going to stretch it, but I can't speak about A&E and congestion without speaking about primary health care. The two are linked. And while we are doing this, and I know governments are often accused of focusing too much of their resources and focusing too much on the Queen Elizabeth Hospital, I think we recognize again, like was the process in the past, that primary health care is vitally important. And perhaps over time we have drifted away to tertiary health care and neglected primary health care. We have 9 polyclinics in Barbados. We recognize that the trend with the NCDs, we need to focus on prevention through education, health promotion. We need to focus on early detection and screening. Having done that, we are able to start treatment earlier and have much better outcomes in terms of the patient's health. And obviously, in the process, reduce the load on the QEH. We need to treat patients earlier in their communities. So the government is now embarking on a project, and we have approached a certain country in terms of looking at funding to assist us, where we refurbish 7 polyclinics. The proposal obviously is to relocate Randall Phillips Polyclinic, which was always dangerous in terms of its location, as when we speak about climate resilience and all of those issues, being right next to the water. So the plan is to build a new clinic, Randall Phillips, at a different area, and also to look at the Eunice Gibson Polyclinic, which is located right in a busy area, difficult access for elderly people, fumes from the area, always traffic congested, and prone to some flooding. So the plan is to build 2 clinics and to refurbish, expand, when necessary, the other 7 clinics, so that we bring all of them up to a certain standard where we can have expanded facilities, recognizing that we want to focus on the NCDs, screening for cancers, and also, of course, mental health. And doing this will take tremendous strain off of the facilities and of the QEH. So that is something, obviously, that members will be hearing much more about in the coming months. Mr. President, I don't know if there's much more I want to say. As I said at the beginning, we've heard the complaints. We have done the introspection. We've had the internal meetings and the planning meetings, and we are now ready to address the issues which have been bothering the people of Barbados as it relates to the Queen Elizabeth Hospital and its operations. And with these few words, I beg to move that this will be now read a second time. I'm obliged to you.
Thank you, Senator Walcott. Senator Walters.
Mr. President, fellow senators, when I think about the Queen Elizabeth Hospital, it evokes mixed emotions. On the one hand, it represents a vital healthcare for our citizens. On the other, it carries the weight of unaddressed issues and challenges that have been echoed by our citizens. I believe that we will all agree that the QEH is central to our healthcare system, and as such, unnecessary tinkering with its administration is not desirable. Mr. President, the stories of neglect and despair that filter through social media and mainstream media, they are real, and there are urgent pleas from taxpayers, especially those in need for assistance. But while we acknowledge that the bill before us addresses the management dynamics of the hospital, it has to be said that there is a fervent hope for a genuine transformative change at the hospital. We cannot and we must not allow our main public care facility to continue into descent into disarray. The average working class person in Barbados, sir, does not have the wherewithal to get up and go to another country or destination to seek health care. They do not, sir, have the liberty to make a phone call or two in advance of their arrival at the accident and emergency department. They do not enjoy the benefit of having their services prioritized because of their stature, sir. I say that because it is our responsibility as policymakers and legislators, sir, that we owe it to the people of this country to get the situation at the Queen Elizabeth Hospital right. We all have a vested interest in ensuring that this institution is working on behalf of all Barbadians. It is always said that sickness does not discriminate. your class, your color, your political affiliation even. So, sir, it is very essential then that the hospital, that we treat the hospital with care, and that we do not have the political meddling in the affairs of the hospital. But to understand the present, sir, I believe that there is some value in going into the past, just briefly. In 2018, when the BRP government came into office, sir, there was a CEO in place. A CEO, sir, that with his leadership had worked with the board of the hospital and the ministers of health to move the Triage from off the front pages of the newspaper and the call-in program, sir. Working hard to bring back the dignity and pride for the stakeholders of the Triage, making that hospital more patient-friendly, more doctor and nurses friendly, sir. He was subsequently replaced, sir. I cannot say if he was fired or if he left. But what we can say for sure, sir, is that he was instrumental. He moved to Dominica, sir, and he was instrumental in providing technical support to the interim board in establishing the Dominica Hospital Authority. Subsequently, he was appointed the first chief executive officer of the Dominica Hospital Authority in 2001. Mr. President, the same individual, sir, moved to St. Lucia in October 22 and was appointed the CEO of the Millennium Heights Medical Complex in St. Lucia, which is the primary healthcare institution in St. Lucia, sir. These are just examples to show that the individual who held the post is being used in other jurisdictions, sir, in a very senior manner as relates to their healthcare and their important health institutions, sir.
Honourable members, let's hear the honourable member, please.
Mr. President, the government in 2019 amended the Queen Elizabeth Hospital Act and did away with the position of the CEO to that of an executive chairman who came with it, sir, many exuberant plans to transform the QEH. Sir, it is no secret we are here to reverse that decision today. A decision that at the time was felt by many that it was made to benefit an individual more than the institution itself. A decision, sir, that at the time was felt by many was not well-intentioned and had the ability to create that political mischief in the operations of the hospital. In other words, sir, the institution was seen to have been becoming politicized. This is how many in the country felt. We are here to reverse that short-lived decision and to appoint an executive chairman and to revert to the previous model of having a CEO that reports directly to the board. Without any apology, sir, this amendment is a full 360-degree turn, and we are back where we started. The question is...
Honourable members, let's hear the honourable member. He will choose his own degrees. Honourable members, he will choose his own mass on the matter. Please, proceed, Senator Watt. Honourable members, please. Honourable members, please. Have
we wasted time and taxpayers' money with this decision that was taken in 2019? Having to reverse the decision, sir, is an admission by this administration that it made a misstep and is now seeking to correct it. Because, sir, if it was an effective structure, we would not be back here to repeal the sections of the Act that speak to the appointment and dismissal of an executive chairman. Mr. President, good organization structure requires...
Honourable members, please, Senator.
Thank you, Mr. President. Good organization structure requires that there's independent management at varying levels within an organization. That is why you would have supervisors, sir, you will have a managerial level, and some institutions you will have a director, senior manager, sir. The board at the QEH is an important element of the operation at the QEH because it offers an independent view of the management of the operations. So it was never a good decision, sir, to mix those two, having the executive chair, having the chairman of the board being an executive officer, because it took away that independence to ensure, sir, that the operations were being done in accordance to the mandate of the Queen Elizabeth Hospital on behalf of the citizens of Barbados. So this is a learning opportunity for this government. A good and sufficient reason why we must not seek to politicize the affairs of the hospital. And I'm happy to hear, sir, that we are moving back to a position where we will have that level of independence in terms of the management structure of the hospital. So unnecessary tinkering, sir, is not what we need at the hospital. It seems, sir, though, that whenever this government is in office, the hospital seems to be the subject of newspapers and calling programs. I heard the admission by the minister. I heard the admission by the minister, sir. But the practice, to move to executive chairman was supported and proposed as a modern management decision then. But we are here now again, sir, a few years after, to revert to an old management system that should not have been changed in the first place. I must remind this chamber, sir, that in 1993, that the DRP administration started the David Thompson Clinic in St. John. We lost the government and the DRP gained office in 1994, and nothing at all was done on that site between 1994 and 2008. The people of St. John had to wait until 2008 for us to resume work on that facility. It is not, that is a good example, sir, of politicizing the healthcare system. We need not to put politics before the interests of lives in this country.
On a point of order, Mr. President.
There's a point of order. Senator Waters, please. Yes, Senator Thompson.
Implicit in the statement of the honorable senator is two things. One, a misstatement which amounts to misleading of the House at one level, and second, that the reason that there was no construction was a politicization of the policy decisions at the time. I'm taking issue, sir, first with an attempt to mislead the House, and second, with what is really an attack on the policy maker at the time, which happens to be me. And I therefore know for a fact that there was no politicization of the issue in relation to the St. John Polyclinic, that the construction there failed or was stopped on technical grounds, and that a number of consecutive difficulties, not policy malice, not politicization, prevented the work for some considerable time. I would wish, sir, that in the circumstances, that the statement be struck from the record.
Senator Walters, the standing orders prevent the accusation of improper motives, improper conduct by members of either House, other than by specific resolution. Therefore, you will therefore withdraw the comment in relation to the politics being the reason for the cessation of work at the St. John Polyclinic, and have it struck from the record.
Yes, sir. I withdraw that statement, sir. But it seems as though all the technical issues that were referred to were fixed in 2000 and after the Democratic Party began office.
On a point of order, Mr. President, sir, the honorable senator is misleading the House by suggesting that no preparatory work was done for the fixing of the issues, and it was because the groundwork was laid and all of the negative issues resolved that y'all were able to start and finish the works for which the preparatory works had been completed.
Thank you, Senator Thomas. Senator Walters, please press on.
Mr. President, I heard the former executive chairman tell Barbados to judge me by my results, in her words. I don't think we have the time to judge the former executive chairman, but I would ask a few questions on behalf of the people of Barbados. Before I ask these questions, sir, I must say that listening to the presentation by the Honorable Minister of Health and Wellness, that one would think that this government came to office last year, because we are now hearing about all these plans to fix the issues and to address the issues at the Queen Elizabeth Hospital. But my questions are, sir, have the wait times at the QAH and the accident and emergency been reduced? Or do citizens still have to endure days of waiting to be attended to? How many Bajans, sir, are still waiting lists on long waiting lists in eye surgery and other elective surgeries? Have more posts been opened up for young doctors who, sir, have been expressing a challenge of being overworked and working for strenuous hours, which, sir, has been admitted that it is not safe for them nor for the persons in their care? Are there adequate supplies, sir, equipment and machinery, and are they in good working condition? 6 years into this Barbados Party's administration, sir, have they sufficiently dealt with the cybersecurity breaches at the institution? Sir, these are questions that, if answered, the Barbadians can judge the performance of this government as relates to the management of the executive chairman and the management of this government as relates to the function of the Queen Elizabeth Hospital. Mr. President, to add insult to injury, this government in 2018 introduced a health levy to finance the operation of the Queen Elizabeth Hospital. The government is the only government that I know that had collected money directly linked to health care. Sir, according to reports, the health levy rates in about 60 million Barbados dollars a year from taxpayers, from workers, from persons that go to work to earn an income. $60 million a year. I believe that is a substantial sacrifice that workers have made. But if they're making the sacrifice, sir, where are we 5 years down, 6 years down, $300 million after with the functioning of this institution? This is not a BLP or DLP situation. This is hard workers who have...
This is a point of order. Senator Leonard.
Mr. President, to get into political fights, but the health levy, everyone knows, rakes in a substantial sum, sir, of $75 million annually and claiming.
Thank you for that elucidation.
I'm correcting, sir, the figure of 60 million, which is really important, sir, and it has important implications for the finance of our hospital.
I'm not in a position to be in on the accuracy of 60 or 75. Please press on, Senator Walters. But thank you, Senator Leonard.
Thank you for that intervention. But sir, a substantial amount of money from workers who are paying directly into the fund, into the operation of the hospital. They deserve to have an account for how the money is spent, and they deserve to feel a difference when they visit that institution. In excess, sir, over this period of 5-year period, in excess or close to $150 million directly from the workers' paychecks. Tell me that they don't have a right to feel a difference when they go to the QEH. Tell me they don't have a right to ask questions. Tell me they don't have a right to see that things are changing and improving after 5 years, over $300 million later. Money, sir, that, as I said, they're making the sacrifice. No issues there. But money, sir, that if you're not seeing the results, could have gone to their livelihoods, could have gone to offset against the high cost of living in this country, paying more than almost double to get to or from work, paying for garbage tax and a sewage levy. So, sir, this is very important part of the running of the hospital. The resources are there, sir. They have an allocation through the estimates, and they have an additional $60 or $75 million a year.
On a point of order, Mr. President.
What's the point of order?
The point of order, sir, is that the honorable member is misleading the House in 3 respects. First, by suggesting or implying that persons are not at liberty to ask questions and that the questions are not being answered. 1. Second, to imply that the resources from the levy are being misdirected somehow or squandered and could be diverted into other development areas, when in fact, the $60 or $75 million, and even less accepted 75, whether that figure is accurate or not, I do not know, really represents a fraction of what it takes to run the QEH. The QEH budget is $200 million plus dollars. So the $230 million. So the $75 million of the levy that is collected really represents just about quarter or thereabout of the budget. It is therefore entirely wrong, sir, and entirely misleading for the honorable senator to suggest that this money is not being utilized toward the overall healthcare budget and is somehow being misdirected.
Continue, Senator Waters, please.
Mr. President, I did not suggest that. I clearly said that the workers of this country have a right to know how the money is being spent. I did not suggest that it should be spent other places. I'm saying they are making a considerable sacrifice by the withdrawal of the sums of money from their salaries, sir, and wages. And they have a right to feel a difference when they go to the QEH. Mr. President, the success of the hospital does not only hinge on this amendment. It does not only hinge on this amendment, sir. It hinges on resolute action to address persistent issues across the length and breadth of the hospital. We are well aware of the challenges that governments in Barbados and across the country, across the globe have. But,
Honourable members, please. I want to hear Senator Waters, please. Calm your enthusiasm, please.
the government and its new management must ensure that the challenges facing the QEH are addressed assiduously. That is all taxpayers are asking. We need to feel a difference. As I said, sir, there is allocation of funds, there is money being invested directly into the QEH, and we deserve to feel a difference. We deserve to feel a difference. It is not a year in office, it is 6 years in office, sir. In conclusion, sir, I want to join with the Minister of Health and express my deepest gratitude, sir, to the QEH's administrative, medical, and auxiliary staff for their dedicated service in the face of immense challenges. They should be commended, and I implore them to keep their heads up high and keep a strong fight going on behalf of the people of Barbados who are depending on them. I thank you, sir.
Thank you very much, Senator Walters. Senator Maynard. Senator Mr. Maynard.
Thank you, Mr. President. I am not afraid to be bitten. Afraid to be stung. Mr. President, I rise, sir, in support of this bill. And I rise, sir, in support of this bill because it's been long overdue. And I think that Senator Walcott has displayed incredible courage because he was the person, sir, who led the debate on the previous bill to bring an executive chairman into being. But, sir, Senator Walcott, said, in fact, in his opening statement, that this should really only take 5 minutes, and I agree. And in the words of Duke Chet E.D. sir, who you remember, these are the good things that that post did. Yes, sir. It was a predictable outcome that we would be here today, and I'm proud that the government has had the courage to come to this parliament to revert to having a CEO. Sir, the Right Excellent JMGM Adams removed the post of executive chairman from the BNB because he saw the wisdom of not having one. That's all I would say. It is not my job to bash the government, but I'm proud that the government realizes it's made a mistake and is fixing it. Now, Mr. President, the QH continues to be everybody's political football. And the only people who suffer every time you kick it are the people who use it. The world has changed since COVID, Mr. President. People no longer care. I've heard it said in this parliament, people no longer care. Compassion is almost a thing of the past in some circles. So what we see meted out to the people who seek medical care in some quarters is only a reflection of what's happening in society. But we have to fix it, because all the people who appear for care are our relatives. There are very few people on this rock, sir, who are not family. I will not go into details as to why that is so, but we are all family. Now, sir, I know that I'm repeating the same thing over and over, but the problems of flow in the hospital will only be reflected, sir, in the flow in the A&E. You cannot have the obstacles within the hospital that prevent flow and expect the A&E to flow. Making it bigger will not solve the problem. When the annex is refurbished, only having just been delivered, and the old A&E has completed, the refurbishment there has been completed, and we then have, I guess, 30-something beds, it will only be a big space that people can wait in for a long time in comfort. You have to fix the problems of flow. And there are internal policies in the hospital about admissions and about referrals that need to be addressed. The notion that every patient who reports to the accident and emergency has to be assessed fully in the A&E in every detail before they are assigned a bed in the hospital is but nonsense, sir. The little department that I work through takes direct referrals. A GP can call and say, I have a problem. In fact, on the weekend, sir, I was not on call, and the patient called me and told me they had a problem who is supposed to be on my operating list for next week, and I had the patient seen from home. It is not impossible. But the people who get paid, sir, to work have to return to work. And those who, sir, are supposed to lead, who are the senior people, whether in administration, whether they are consultants, whether they are in charge of the other services in the hospital, they have to lead. And it's not enough, sir, to come into this chamber, sir, and beat on each other. We have to do the right thing, Mr. President. Now, it saddens me a bit, Mr. President, and I do not support the notion that one should ever change legislation to facilitate individuals. But on this occasion, sir, I have to say that I support this legislation. And I support it because to have brought the position of executive chairman created a series of problems. And for me, the biggest problem was, sir, a person who sat as executive chairman, sat essentially as CEO during the day, and in the evening went into the boardroom and could implement whatever bad thoughts they had during the day. I'm not at all saying that there were bad thoughts, but that possibility exists, sir. There should be clear separation, sir, to indicate that the CEO takes instructions from the board. And I'm pleased that the institution will be returning to that. Mr. President, our nurses, and when I say our nurses, I mean all of our nurses. I do not mean Barbadian nurses in particular, I mean all of our nurses. Barbadian nurses, St. Lucia nurses, Ghanaian nurses who've given tremendous service, Filipino nurses, sir, some of whom have become Barbadian citizens to be here so long. All of our nurses need to be recognized and praised for the efforts they make. But sir, I had reason to look at the salary scales for nurses and teachers. And I'm not complaining about the pay of teachers. I am not complaining about the pay of teachers. A nurse in Barbados gets a degree. Teachers also have degrees. But sir, a nurse starts at Z23 in the Z scale. A teacher starts at Z16.
You have to put the numbers because the Zs will be there.
Okay. There's a scale of pay that we all have had, and we see it in our, who has it, doctor? Isn't it? But the higher the number you are in the Z scale, the less your pay, essentially. And as I move up from the bottom to 1, you've reached the top of the scale. A nurse, when she's reached the height of her pay scale, is at least 6 scales lower than a teacher at the top. And I ask, if they both have degrees when they enter, why do we have the discrepancy? We need to fix it. Because if every year we have to stand and say, we have to get more nurses, nurses are leaving, and people have every right to seek greener pastures and look for better things for themselves and further professional development and some return. We have to look at parity and say whether nurses, in fact, should have a better start, sir, on this scale and end at a higher point. And the work that a nurse does, sir, I believe is no less than many other civil servants, including teachers, sir. And I picked teachers because it gave a good comparison. But sir, doctors, young doctors, who get criticized for sometimes not performing as some people would expect, are also frustrated. And they're frustrated, sir, by administrative policies, We know that there are more doctors being graduated every year than there are posts to fill for all them to go into when they finish internships. And it means that some doctors have to go into the community as independent practitioners. Now, sir, what it means is that when you are employed in the QEH as a doctor and you do not have a post, you are employed, sir, on short-term contracts, usually 3 months. But you may work, if you are lucky, for more than a year on recurrent 3-year contracts. If you're one of those unfortunate people, it means that you are not paid contract maturity, sir, nor are you given vacation pay, even though legally you are supposed to have it. To avoid that, sir, there has been a trend of giving people contracts for 9 months and then stopping. It is wrong. You cannot get loyalty, sir, if you treat people less than human. So we have to fix some of the little problems that we are creating. And I say we because as a senior doctor, I'm supposed to be not only a patient advocate, but an advocate for my colleagues, because they'll be looking after me when I leave medicine, sir. So they also look after Senator Walcott. Hopefully they'll do it well. Mr. President, now, I'm not going to delay this chamber very much, sir. Senator Walcott spoke about planned improvement in our delivery of oncology services, sir. And I'm not going to argue with him about whether he has given enough facts or not. But what I will say is, sir, that this country has the uncomfortable position of being in the top 10 worst countries for outcomes in breast cancer in the world. In the world. And we have to fix it. It requires expertise, it requires equipment, and it requires money. And we have to find the funding and the expertise to fix it. We do pretty reasonable in the early stages for breast cancer, sir. But for the later stages, our results are not good at all. I am sure that my colleague, Senator Haynes, will elaborate further, sir. But we have to fix it. And we have to do the same for prostate cancer and colon cancer, sir. So I'm pleased to hear Senator Walcott speak about future plans. There'll be more time for speaking, sir, on such things in the near future, sir. Now, Mr. President, if our institution, the QEH, sir, collects over $75 million a year, which, through the NAS, which is paid directly to the QEH, it provides a lifeline, sir, of steady income. And anyone, sir, can check and see that, because there's no secret, I am pretty high on the pay scale in government, sir. And 3% of my equivalent pay is paid to the NAS every month. And it means, therefore, sir, that I will be able to purchase a reasonable insurance policy with the money that is deducted from my salary every year. And if we looked at the deductions as insurance policies, it would mean that people, apart from paying their normal taxes and VAT, are now paying a special levy for healthcare at an institution. And I think, therefore, we are obligated, sir, to deliver it. Those of us who work in the system, sir, and those who are responsible for the administration of the system have to step up to the plate. Now, sir, I want to spend my last few minutes, sir, speaking about the A&E, the Accident and Emergency Department. And I wish I didn't have to do it again. A short time ago, sir, the hospital took possession. It was during COVID. The hospital took possession of the annex to the A&E department a short time ago. Government at the time had provided $11.2 million for the refurbishment of the A&E. It was deemed that that was not enough to refurbish the old A&E and complete the annex. Excuse me. The government approved and provided another $5+ million for the project. Remarkably, the government is spending money to refurbish a building that is only 3 years old. And I have to ask, why would someone be refurbishing a house if it was only 3 years old? Why, if a building is built to specification with all the money that was spent on it, why would you have to refurbish it in 3 years? Could it possibly have fallen apart that fast? I could not go and see why, because according to the administration, I've been given a notice saying that members of staff are forbidden from visiting the premises, so I couldn't go. But Mr. President.
Mr. President, on a point of order, I believe that the member is misleading the House. From what I am made to understand, what is happening right now is the completion of phase 3 of the accident and emergency expansion, and not a refurbishment of existing works.
Senator Maynard.
1 second, Mr. President. I should probably not do that. I do have an email, sir, from my phone, where it says that members of staff are forbidden to visit the A&E site. It may well be, sir, that the A&E that was handed over is in pristine condition and does not need to be refurbished. And I'd like to believe that it's true. I would like to believe, sir, that what we just heard in this honorable chamber is true, and there's no refurbishment being done on the newly handed over A&E.
On a point of elucidation, you don't need to sit. Just being clear that it's phase 3 of the expansion project. Phases 1 and 2 have been completed. Those were the works that were completed within the last 2 years, and I believe that handover is expected at the end of this month for phase 3 of the project. Those are the ongoing works.
And you can therefore take it as true as spoken in this honor of the Senate.
Mr. President, government built with the taxpayers' money an annex to the A&E. 2 buildings side by side. If I told you, sir, you have to go down a ramp to get to the new one, you might find that impossible to believe. That if you are in the annex and you go into the old A&E, you have to go up a ramp. And if you are in the old A&E and you're going to the new one, you have to go down a ramp. And I asked, was that by design or was it a mistake? I can't imagine, sir, if you're expanding your house, that you will ramp down to the new part. I would like to believe that with all the considerations for safety in a hospital, you would have built it at the same level. But I am not allowed to see it, so I cannot comment. The public will make their own comments, sir. That's not the government's fault, sir. The government pays people to do these jobs. Pardon me?
On a point of
Please
order,
address the
Mr.
chair.
President, sir.
Yes, what's the point of order?
The point of order is that the honourable member imposing his comment during the course of his speech today in the way that he did by saying that staff members have been prohibited from entering this site. While it is true, it may be for their own safety. People are prevented from entering and being on and curiously looking about active construction sites for their own well-being and safety. And if the honourable senator in fact got such a letter, it is because the government wants to keep him safe and well so that his skills will not be lost to the people of Barbados.
Thank you very much, Senator Thompson. Valid point. Press on, Senator Maynard, please.
Mr. President, it was long past that point. Mr. President, the active use of the A&E as it is, the building is not going to change. When the refurbishments continue, the building and the levels in the building will not change. They will be the same as they are today, as they were yesterday, and they will be tomorrow. Hopefully, sir, you will never have to experience it. Now, Mr. President, we've got the unfortunate situation, sir, where people have been waiting comfortably in some circumstances, and sometimes not so comfortably in other circumstances, in our A&E, and are not surviving. And we have to really ask ourselves whether there are problems that exist that can be fixed easily. And we need to address it, Mr. President. We need to address it, Mr. President, because it cannot be good for a hospital to be finding persons within a department who have ceased to breathe, especially if it's an A&E. So the persons who manage the hospital, the persons who manage the A&E, the persons who are paid by the government to do the jobs have to do them, Mr. President. They have to do it, Mr. President. The Prime Minister can't do it, Mr. President. Senator Thompson can't do it. The people who get paid, people get paid every month. And during COVID, when people had problems who got paid every month without delay, have to do their jobs. And they have to be held accountable. So hopefully, Mr. President, when this amendment is debated and passed, whosoever, sir, sits in the chair at the top and gets paid to do the job shall do it. And I hope, sir, that the decision to do the amendment and employ someone will bear fruit. I thank you, sir.
Thank you very much, Senator. Mr. Maynard. Her Honor, Senator Thompson.
Thank you very much, Mr. President. I start by apologizing for my hoarseness and the fact that I may, from time to time, have to use a tissue. I just want to assure the honorable members of the Senate that I'm not contagious. I am just extremely allergic to Sahara dust and have had very, very severe reactions to it, and to the point actually of being on a very serious, that is why, sir, I spoke just now about the honorable senator's skills having to be preserved, because clearly I need to put myself in his hands and say, save me, because I have been on a regimen of meds for weeks that includes steroids, antihistamines, antibiotics, and you can still see that I am really not well. Sir, I had not, to be honest, intended to speak in this debate at all. I had not intended to speak to this issue. But there are perspectives that I want to bring, having been a Minister of Health, sir, from 1994 to 1999. And the truth is that even having held that post, I would still not have spoken had the honorable senator from the opposition not raised some of the issues that he did. So I'm going to make a very non-political speech, but I start with a very political point precipitated by the comments and remarks of the Honorable Senator Walters. In 1994, when the Barbados Labour Party became the government of the day, and in 1995-96, I was appointed Minister of, no, I think in 1994 I was appointed Health Minister. At the time, we came out of another period of very poor DLP governance. Salaries had been cut. There were no resources for public works and construction and repair. It was a difficult period. Difficulties always seem to attend DLP leadership, governance, and their time in government, sir. The St. Joseph Hospital in the north of the island had been built or refurbished and was being run with staff. Millions of dollars had been diverted from the QEH budget to the St. Joseph Hospital, but it was not for at least 3 years, sir, in any position to receive patients. If you had fall down, burst your toe, did they have a plaster down there to wrap it up, sir? It was almost a vestigial organ being financed by taxpayers, unable to give service or relief to any single individual in this country. But it had a fully functioning gym, fully equipped and fully functioning gym. Sir, it really, because a lot of the people now associated with it have gone to the great beyond and have had to face their God, I really don't want to speak to some of these issues, sir, but I'm raising them because I heard today about politicizing the St. John Hospital. The thing was, sir, that we were so cash-strapped at the time, apart from the technical difficulties with St. John. We were so cash-strapped at the time that we had to immediately funnel millions of dollars back into the QEH in order to provide care and to keep some of the other polyclinics going, that a choice had to be made relative to, thank you very much, I was actually going to look for the figure, relative to what the needs were. In fact, sir, in 1991, the budget of health at the time, QEH, was $67 million. 1991. By 1994, it had dropped to 58 million because the money was being sent down to the St. Joseph Hospital. That is why there was not immediate resources to deal with the polyclinic in St. John. It wasn't any kind of political malice. My mother was born in rural Barbados. There's no black Barbadian, no Barbadian, and no rural Barbadian who I would make any policy decision to deny them care or dignity in this country. It would not happen. When I became a minister of government, I made a promise to myself. I'm going to tell you, sir, a personal story, because really this morning I became very annoyed. I did not intend to speak. I mean that. On the day that I was sworn in as a minister for the first time, sir, you were there, because you too were sworn in as a minister. And it was a different format to what is used now. And we had to rise the stairs at Government House as it then was, to be received by Her Excellency, Dame Nita Barrow. Sir, we went in order of age and precedence. You were in front of me. Mia Motley was behind, as she then was. We went with our supporters, our families who were allowed to attend. And so you could imagine this sweeping procession. Those of us ministers for the first time, some of us entering Government House for the first time, going up. This winding staircase to be received by the president. It was an auspicious moment in our lives. And in terms of that election, it was a momentous election as well, that 1994 election, with the government having been felled by a no confidence motion in which people on the government side voted with the opposition. And I turned back, sir, to say something to my mother, who would have been behind me. And when I turned, my mother was standing on the steps of Government House crying. And I said to her, "Oh my God, Mom, what happened?" And she held my hand and squeezed it. She said to me, "In all my days living in poverty and scrubbing people's toilets, I could never have imagined a moment like this." And in that instant, I understood what it meant to barefoot Black people from the country, to see their child not only become a lawyer, but become a minister of government in this country. And I understood my duty and responsibility to the people of this country, and I have never and will never resile from it. And I swore an oath that I would go to bed every night happy with the person whom I saw in the mirror, that person had gone to bed doing the best that they could every day. So please don't ever come in here again and accuse me of any kind of politicizing of something like healthcare, and you can sit and laugh. But if you ever get to serve at this level, and if you ever serve with sincerity, you will understand what it means. No, and you can dismiss me, because you see, but I will deal with you. We will come to the budget. Sir, so that is the background to what happened in 1994. We also had very, very serious nursing shortages at the time. Nursing shortages that were caused because the fail rate for the nursing exam at the time was over 70%. And all of that had to be corrected. How could you have a system where 70% of your student population was failing exams year after year, session after session, and nobody was correcting it? The challenges were myriad and had to be corrected. Now, I served 94 to 98. The government, BLP was in government 2000, 2008. Challenges in health at various levels continued. At that time, in 1994, Branford Tate had been the health minister. And I'm going to come to that in a minute. In 2008, when we lost office, I sat in here, down there, and heard all the jeering about how incompetent the Barbados Labour Party government was, and how much malice and politicization, all these accusations, and how the Democratic Labour Party government was going to get it all right, that all the issues at the QH would have been fixed forevermore. Amen. And so on. All of that, I sat and heard. And sir, since 2008 to now, we have come back the same cycle. And I've said that I'm not speaking in a political manner, and I turn now to those issues. With your permission, sir. the levy, and I'm going to repeat, which rates in, let's say $75 million, sir, is only part of what it costs to run the QEH. The QEH bill is $230 million. Let's understand that even though Barbadians make a contribution, that really our contribution is so minuscule to the overall healthcare costs. Sir, I had a problem in the United States. I spent 3 days in hospital. $25,000 was what it cost. 3 days. I had a problem with a tooth. $3,000 to be paid upfront, even though I had insurance through the United Nations. So when we talk about health care, Barbadians get free health care. And it is not unreasonable to ask for a contribution. And yes, I agree that the public is, of course, entitled to understand how the money is spent. And I want to thank all those staff members who work diligently to ensure that care is delivered and that citizens get value for their money. I believe, sir, that we have to ask ourselves a number of questions relative to health. 70% of the QEH budget, after administrative costs are taken out, go towards the treatment of NCDs. That raises the question as to whether or not we are to have a different model of primary health care, which is more interventionist and which will address care at the community level and at the intervention level prior to the point where the stroke set in, the serious heart ailment set in, the complications of diabetes set in, and the high cost of care are driven up. Because there was a point when people used to be hospitalized for a very long time. Now you have a lot more day care, 24-hour and 48-hour care in order to reduce your bed utilization and your hospital costs. As a result, because our costs are being driven in Barbados by the NCDs, our bed stays remain extremely long. And therefore, unless we can make the community and social interventions in relation to the NCD crisis in Barbados, then we are not going to be able to change the outcomes or the impacts on the QEH. That is the first point that I want to make, sir. I move from there to the point to make this point. It is easy for the Honorable Senator to get up and try to ask questions, some of which some might think have political impact. I will say this. At my age, sir, and having served as a health minister nearly 30 years ago, I have seen many ministers of health. I have seen changes of administration. I have seen administrations try, and health ministers try, and I have seen administrations cry and health ministers cry as a result of the state of the QEH. That is just the reality. I have seen physical upgrades by both administrations. I have seen the introductions of new programs, new healthcare centers, new medical interventions, and more sophisticated technology and healthcare mechanisms, bad word. But I think you understand what I mean. We went to very high-level heart interventions, very high-level cancer interventions, and so on. The QEH is the most complex organization in the country or institution in the country. I'm going to repeat it, sir. The Queen Elizabeth Hospital, from a management perspective, when you consider what it is expected to deliver, when you consider that it is the only tertiary healthcare institution that we have at that level, when you consider the number and various people and skill sets, from highly skilled technical specialists to janitors, maids, and orderlies, the range of blue and white collar workers, the range of knowledge sets, the range of social attitudes, the range of understanding of what their role is to whether, oh, I just got a job. The time we clean the hair balls, I get tired of going home. That is what we see, and I'm going to come to that later on, sir. It is the most complex organization in the country to manage. And if government has made an error in terms of the model at which it was looking, which was created not for political reasons, but for national improvement reasons, looking at the institution, identifying challenges and saying, what can we do differently to make a difference? And you have to admit that the person who is now or was the subject of the criticisms being made impliedly by the honorable senator really did do some good work during their time there at the hospital. But the demands today at a modern hospital with a population suffering from everything to stress, from stress-induced illnesses, to environmentally induced rashes and skin conditions, to rhinotracheal diseases, to heart conditions, to whatever the challenge is. We are talking about a very large, complex organization. It is the largest organization in the country, with the largest budget in the country. Management of this organization cannot therefore be easy, simple, or easily addressed. When I was a girl, sir, there was a health minister called Ramesses Scattle. You know, I like paper. Send me some paper. Old people like paper. So when I was a girl, I'm being passed a note, but it is difficult for me to pick it up, sir. When I was a girl, there was a health minister called Ramesses Scattle. And then, when I was still a girl, there was a health minister called Billy Miller. And when I got older, there was a health minister called Cyril Walker. And there was a health minister, as I got older, called Branford Tate. I succeeded him, and I could go on and give the names of the various health ministers, sir. There was a health minister called Liz Thompson. There was a health minister called John Boyce. There was a health minister called Philip Goddard, who people said, oh, management specialist has now come. And he was going to solve all the problems in the healthcare system, sir. From the days of Ramesses Scattle to now, sir, and we are talking about perhaps back in the 60s, 70s, to now, sir, the problems at the hospital were long waiting times at A&E. Long waiting times to get medicine. Long waiting times. Long waiting times. Long waiting times to be seen. Appointment lists that would give you an appointment that is 3, 6, 9 months on. Triaging times and methodologies in the accident and emergency department. The number of services given by the hospital and the cost of those services. Equipment maintenance, equipment breakdown, and equipment missing, sir. When I came, there was the problem, sir, of people getting paid who were not even on staff members of the QEH. That was another big scandal that we had to deal with. dead people collecting money, sir. All of that the QEH has seen. I'm continuing with the problem, sir, that I have heard about since the days of Ramesses scandal. Adequate staff in various departments or inadequate staff so that when a particular person does not come to work, one staff member, that services cannot be provided in the department because that person may be a critical member of the caregiving team, and service cannot be delivered without that particular individual. Somebody who is operating a critical piece of equipment. So equipment, apart from maintenance breakdown, whether we have the right set of equipment or the wrong set of equipment, that has also been a challenge. What is the right type of equipment for a hospital the size of ours, expected to deliver care to the number of people it delivers to act as a training hospital for the number of interns for which it must act? Because what a lot of people don't know is that there is a particular ratio of beds and specialists that you need, and that drives the number of interns that you are able to train. So it isn't that, oh Lord, my daughter's an intern and the one takes she at the hospital, the government victimizing me. That's not the issue. That's not how it functions. Sir, another issue that there had at QEH from the time of Ramesses scandal to now was pilferage. Sir, I mean, whole things, people used to come and walk out chairs, whole pieces of things, small things, large things. People bought equipment and they don't bring it back. Bed sheets and linens. Toilet paper get ordered, but toilet paper cannot be found on any wards. You ask for medicine, well, you got none of that. But to tell you it is downstairs in the supplies. Sir, what we are, another challenge has been the fact of complaints that the hospital is too specialist-driven by consultants who give their private patients priority over public patients. All of these are the complaints that you're hearing now, and these were the complaints you heard when Cattle, when Miller, Thompson, Walker, Tate, Walcott, everyone. Well, I ain't talking about Innes at all. Oh, no, the complaints under Innes were bad. Boys, every health minister, we've heard the same complaints. I can speak now, sir, as an old woman on the eve of retirement. It is time for us to really ask the serious question. Oh, one last thing. Yes, I'm going to come back to that. What are the systemic problems at the QEH? That's what it is. It is not politics. It is not BLP malice or BLP mismanagement. It is not DLP malice or DLP it is DLP mismanagement. It is not, but it's not DLP malice, sir. But it is some measure of DLP mismanagement. The issue, therefore, is what are the systemic issues confronting the QEH as a national institution? The institution that if any one of us drops down in here now, I don't care how much money we have to be rushed there. That people like my mother who know what it is to clean people's toilets for a large part of their life, they have to be rushed there. How do we prevent, sir, the development of a two-tiered healthcare system so that you have a hospital which serves only the poor and those who cannot afford it, because the rich can go overseas, or the rich can get access to private care, or the rich can pay the consultants and have the maid bumped off of the waiting list while they go to the top of this waiting list for the surgery or the treatment. Because often people tell you, well, the doctor tell me that I will got to wait till somewhere about December. But he tell me if I could find $15,000 that he will see me next week. People tell you this. Now, I am not in a position to say the extent to which this is prevalent, the extent to which it is true, how many consultants it relates to, but there is a sufficient complaint that it warrants investigation and addressing. I have accessed healthcare outside of Barbados, and I know that you have to go in to A&E departments and wait. But are the waiting times in Barbados reasonable? Are they reasonable in is the triaging system adequate to identify those persons who need care urgently? A person who has had a stroke or may be having a stroke can be helped if they are seen quickly. If, however, they're going to wait for 36 hours, they cannot be saved. It brings us then, sir, to what to me is beyond the systemic issues, another fundamental issue in the hospital. Excuse me again, sir. A lot of what people complain about, and there's no issue that our people are highly skilled and can do exceptional work. But, sir, a lot of what people complain about in relation to the QEH is attitude, the discourtesy with which they are treated, the fact that people will not look at them, the short and abrupt answers that cut you to the bone when you're lying down there or waiting there, waiting to know what the outcome is going to be, waiting to know if you might live or die, waiting to know if you can see a doctor, waiting to know if your life will be saved. Just treat people with a little more courtesy and respect. Treat them with a little dignity. Touch them and make them feel like human. Tell them some soft, reassuring, kind words. It is attitude that really, really causes the problem. And you have to ask, what causes me as a Bajan to look at my brother and sister and feel that I shouldn't treat them with respect or courtesy? Feel that I shouldn't treat them with the kind of kindness that I would want to be treated with. So, sir, we come then to another fundamental question. What is the bundle of services being delivered at the QEH? And can we afford them as a small developing country with a population of only 270,000 people, the majority of which are aging, the majority of whom, beg your pardon, are aging? What can the country afford? How do we create career paths for those who work in the system and assure them some level of job satisfaction? How do we create public confidence in the institution? What is the optimal size of the staff by department, by specialty, by skill set, by training, based on redundancy, and based on the fact that you can't only have one person trained in a particular area because that person needs holiday, will get sick, will have a problem a day, you have to have more. What is the optimal size of the staff that QEH needs to deliver care across specialties, and what will that cost Barbados? What can we do then to find those resources? How do we go on a massive recruitment drive to fill the HR places beyond nursing, to find the specialists that we need, to find the people who can do the work across all levels at the hospital? And that is what I mean by what is the optimum staff? Can we afford it? How do we recruit it? And how do we get that staff in place? What is the budget we should have in order to be able to deliver care? Do we have to increase the levy? Should we float a bond at the national level? Should we float a diaspora bond? What percentage of the government's budget and the allocation of the government's budget to healthcare is already extremely high? What percentage of the government's budget is to be allocated to healthcare? Mr. President, I know, and to the QEH in particular, I know you signaled to me that I had 5 minutes left. I cannot make some of the other points that I want to make, but I trust, sir, that the terms in which I have spoken today will be of some assistance to the smirking senator and to those members of the public who criticize administration after administration, and to those who work in the organization, for policymakers now and those who will come in the future, to ask themselves the critical questions about systemic problems at the QEH, because I am entirely satisfied, having paid attention to this matter for more than 45 years, that successive administrations have sincerely tried. But successive administrations have not been able to achieve the level of success to take the QEH out of the news and to have a majority of people say, yes, we had some problems, but by and large, we are satisfied. The criticisms don't only come when the Barbados Labour Party is in government. If you take the time to do the research, you will find that this is a problem that is a national problem, not a political problem, and it has plagued successive administrations. And I believe it has done so because we have tinkered, sir, all of us. We have been so busy opening fires. You have a problem of nurses, you rush and get some nurses. You have a problem of equipment. Another thing that we need is a proper digital system. You go to the QEH. You go from department to department. Everybody come and tell, where your name, where you live, where you come here from. And they ask you the same questions over and over because there is no central digital system that once your name is put in, that everybody from finance, I had to go from finance to the wards. I had to go to QEH and beg to be given a bill, a healthcare bill for my mother. And they laughed at me and I said, listen, the Dems are in office. I'm a BLP supporter. I left in here without a bill. You bring it. And I stood up. And it took hours. They had to call this department, call the next department in order to get things. That should all be centralized. When I went into hospital in New York, they asked me my name. They took the information. It was entered into thing. They put a thing on my hand. Wherever I went, somebody picked up a scanner, a device, scanned it and said, confirm that you are Henrietta Thompson, your date of birth is so-and-so, and you are here for X. Including right down to the last little bit of tablets, sir. Half a tablet. Okay, so your bill for drugs is this, half of this, half a tablet, or 2 tablets for that, a bandage, an ointment, and so on and so forth. Sir, I am satisfied that until we stop the outing of fires, put proper planning in place, and address the QEH as a truly complex organization in terms of management and in terms of what is anticipated it will deliver, and deal with the systemic problems that have plagued us, sir, since the 1960s, that I will be at home resting in my armchair with my foot up, and I will hear the same complaints being made again. And so I will drink my Morby and say, Kadir. Much obliged, sir.
Thank you very much, Sir Honor Senator Thompson. Speakers? Senator Haynes. Did you just raise? Are you not ready? Okay, close then.
Thank you for recognizing me, Mr. President. The QEH, as Senator Thompson would have explained, is a common issue of public debate, as she explained, because it is the largest institution in the country. We are the largest and single employer in Barbados. And at the end of the day, whether you are a member of the Senate or a member of the general public, the buck always stops at us. There are a plethora of private healthcare institutions popping up, but at the end of the day, you can go to Sandy Crest, you can go anywhere else, but usually if there's a complication, you will end up in A&E. And that is in large part because the range of specialist services and specialist skills are concentrated at our only primary care institution, at our only tertiary care institution. And I just wanted to start by saying that in spite of all of the complaints that we commonly hear in the public domain, we have the most dedicated team of public servants who, regardless of board, who, regardless of minister, are there day in and day out, keeping the institution afloat, even through the transition period that we have gone through between having the former executive chairman and the incoming CEO come into place. I think in a large part, the public discourse around the hospital tends to be negative, but it is unfairly so because overwhelmingly the concentration of the debate is centered around experiences in the accident and emergency department. And those experiences, like the member for the opposition said, are real experiences that we have to acknowledge. We have to acknowledge and accept where we have failed, where we haven't met the mark. But as you would have heard from our very able Minister of Health, himself a former Minister of Health in a previous parliamentary term, a current Minister of Health, and an esteemed surgeon, his heart, his commitment are in the right place, and we are fully committed to getting the accident emergency department on track. I've sat on the hospital board for about just under 2 years, and I can tell you that one of the first things that we did in acknowledgement of the weaknesses that people were experiencing in the A&E was to bring in a team from the Northwell Health System. Northwell is the largest single private healthcare provider in the entire northeastern United States. And they had a dedicated team come down to Barbados to assess what exactly would be the niggling issues plaguing the accident emergency department. You will be surprised to look at that report to find out what they said. They identified that the QEH Accident Emergency Department has all of the necessary skill sets, all of the necessary equipment, and the ratios of doctors and patients and nurses to patients were comparable to what you would find in any other health system. What they did identify, as Senator Maynard would have alluded to, were challenges related to the processing and the flows through the department. And some of these aren't isolated to the emergency department itself, but are hospital-wide issues. And I just want to briefly address how we have been seeking to address some of these things. So when someone presents to the accident emergency department, the first thing that happens is a process called triage. Basically what we do, you come in with a specific complaint, and based on the nature of the complaint, we are able to identify, okay, this is a gunshot wound that might have to go to operating theater, or this is someone who has stumped their toe and might have to sit and wait. There are different levels of urgency required to attend to different complaints. What we've actually managed to do is, based on our triage system, you are labeled either level 1 down to level 5 being the least urgent, and we've restructured the triage system in a way that they're dedicated teams. So there's a team specifically responding to the urgent and emergent cases, the middle tier cases, and then the non-urgent cases. So we're tackling it from 3 different ends to make sure that there's some responsiveness happening. And rather than people with a stop till waiting for 4 days, there's always someone there still trying to process them, while of course making that the most urgent life-threatening injuries the strokes, the heart attacks, and the life-threatening injuries can get the care that they need. But just so you know, the accident emergency has the requisite staffing levels. The staff are qualified, competent. We've made the relevant resources available in terms of testing and all of these different things. You would have also heard the Minister of Health make reference to further investments happening, not just in the physical expansion of the plant, but investment in terms of human capital. In the upcoming budget, and I will encourage everyone to follow in what's happening the other place tomorrow, you will hear more about investments in human capital. The minister has alluded to the fact that there's additional staff being assigned to the Accident and Emergency Department within the coming financial year, but we have looked at issues related to flow through the department. One of the other things I wanted to address was the issue of what we call bed block. So typically what's happening, you've already been assessed by the Accident and Emergency team, and this is where a lot of the bottlenecking happens. A&E has done their job, but you are still in the department. Usually there's a case where the Accident and Emergency doctor now has to refer you onward to a surgeon, to a gynecologist, whatever the case may be. That gynecologist might be upstairs in surgery. That surgeon might be on the floor seeing patients already. So sometimes there's a bit more weight added to the process because of that. And I think a lot of times people don't understand the processes that are happening, but what we have been able to do is to implement what is called a bed management unit with a dedicated bed manager whose job it is specifically to look for opportunities for us to find patients who are well enough to, well, they've convalesced, you can go home and we can continue your care as an outpatient. So we're actively looking at ways of freeing up beds on the upper floor in order to decant the A&E and to help get the process going. One of the other long-standing issues that we've had is that with elderly for care patients and young for care patients. You will be surprised to know that as recently as December, so we average roughly 40 elderly for care patients a month. We narrowed that load down to 2. We basically were able to get the patients off to geriatric hospital, district hospitals, and nursing homes that the government supplements the care. By the next month, we were back up at 36. So we also have an issue. Sometimes there's social circumstances where the family members can't commit to looking after someone with dementia. They might have a feeding tube, different issues. You can't always judge people whose relatives end up in these situations. But these are some of the realities that are creating a direct impact on your experience, your patient care, your wait times in the ER. And I can tell you it is not a case where the hospital's board is not directly looking at ways to tackle and get on top of these issues. Because I think we can all agree, regardless of whatever side of the table that we're on, any of us or our relatives can end up there any time of day, and we want to know that we can get the kind of care that we want. So just to get the A&E issue out of the way first, I need to make those points. Now, I also have a unique perspective, having served on the board under the former executive chairman. And as I've sat here, I feel like she's been dealt with quite unfairly. We've heard that we've made a mistake. We've heard about whatever bad ideas she's had brought to bear. I first off want to say, because many suggestions have been made that the decision was a political one. Many people might not be aware of the former executive chair's background. She's an attorney at law, first off. She holds a master's in healthcare administration, health policy, and health economics. She served as a regional director for, I won't call the name of the organization, but it's an international body that manages healthcare regionally. And she took a pay cut to take the job that she took. I'm going to put to you that regardless of who she's married to, she was highly competent, highly qualified, and I can tell you what we were able to accomplish as a board with her as our executive chairman. A joint program that was defunct for a decade was reinstated. Started back doing knees, and started back doing knee replacements and hip replacements under her tenure. A backlog of 490 cataracts. We got the ophthalmologist to clear that backlog within probably 2 months. Backlog that was there for years, dating back to my time. 3 wards were renovated. We renovated B4, C5, and Ward C9. We increased the ambulance fleet. One time people calling the ambulance service can't get an ambulance. Went from 5 ambulances to 9 ambulances under her tenure. We got the cancellation rates for surgeries down. We started implementing a system where we're encouraging surgeons to start surgery at 8 a.m. sharp to keep the operation day on time. We doubled the revenue generated from the hospital, from private patients, because we're using the funds generated from private patients to supplement the care that's being offered to people who might not be able to afford private care. The 24-hour cardiac suite program was started under the former executive chairman. We also started a special national project, and this was one of the Prime Minister's special initiatives. It's called the Transitional Community Care Program. And what we were aiming to do, once again, back to accident and emergency. There are many patients, as the Honorable Deputy Speaker made reference to, who have chronic non-communicable diseases, whether it's hypertension, diabetes, kidney issues, they're on dialysis, and they're what we call frequent flyers. They come to A&E all the time because there's always something wrong. With that in mind, we established a special community-based unit comprised of doctors, nurses, and community health liaison officers that go directly in the communities to people's homes. They're helping with dressings. They're making sure that they take their medications on time, because we're trying to keep you from coming back to the same A&E that's overwhelmed with surgeries all the time. That was something that was steered by the former executive chairman. We also started the patient relations department, headed by a physician. They have a call desk, a help desk. We started also doing the pharmacy delivery program. One of my mother's neighbors, an old gentleman that has a disability, he's able to get his medication delivered to his home. All of those are programs that were steered under her. Not to mention, nobody who's spoken so far mentioned that we were in a pandemic for 3 years. We saw a situation where we had to build up Harrison's Point. Harrison College became a field hospital. Queens College became a field hospital. Primary schools became field hospitals. I think we almost forget that we just lived through one of the most earth-shattering experiences, and the same executive chairman was at the helm, working shoulder to shoulder with the Minister of Health and his team, making sure that we didn't have the level of deaths as a result of COVID that could have resulted. We watched our neighbors to the north struggle. We watched a mass grave being dug in New York City. But the head of the WHO could commend Barbados on its management of the COVID-19 pandemic, in large part because of the same executive chairman that we're bashing. And I just wanted to stand up as someone who has worked alongside her to also say, typically, boards in the public sector meet once a month. I will say the level of nimbleness, responsiveness, agility that was required during that time, I was glad that that system was in place, because there's no way during COVID that we could have done what we did successfully unless we had a situation where some person who was dealing with the day-to-day was able to report to the board and allow us to very, very rapidly fall into place and to respond to the issues that needed responding to. So I'm grateful that for the time that we needed it, we were able to work under that system. But I can also say that I'm now on the board as well during this time as we transition. I want to pause to recognize all members of staff of the QEH, from the janitors, the orderlies, the carpenters, the engineers, right up to the executive level. There's some talent there who has been there from, my mom worked at the QEH. She used to be HR director, actually at the time that we transitioned to board. And for me to be on the board at a time when, if I may, I'm being pleasant and favorable towards them, and I use their names. Members like Tony Harris, who sits as Director of Medical Services, and Ms. Bob, These are people that I'm really excited to work alongside, and they are the ones keeping and who have kept the organization stable and kept everything afloat during this transitional period, and I wish to commend them publicly for their work. But I will also say, with regards to the new CEO, there was reference made earlier to the politicization of certain parts of the process and so on. I was sitting on the CEO selection committee, and I can tell you, as the minister alluded to, we fielded 84 applicants, 2 were Barbadian. And it crossed my mind. I said, there's no way that a country with free university education, we know we have we have one of the most highly qualified and experienced workforces, that we can't find talent right here to fill this role, but people just didn't apply. And I wonder, honestly, how much of it has to do with how we treat people in these roles. Because I can tell you, if I had the qualifications, I might not have applied either, because I saw how the exec chair was treated in the public domain. What would make me want to apply? But at the same time, we complain when foreigners now come and apply and get the role. But anyhow, I will say, I wanted to address as well the notion of the politicization of the process. We went through so many different tiers in the selection process. There are parts of the process that we were blinded to, meaning we don't know what they look like, we don't know their name, we don't know where they're from. We're just assessing at face value what is put in front of us. The process was designed to a T to make sure that at the end of the day, our minister had no part of this. It was strictly board, and not just board, a subcommittee of the board was designed to do this. I can tell you parts of the process were blinded. We didn't even know where they were from, what they looked like. We were just strictly looking at what are the qualifications, what are the experience, what are the personality traits, because we're not just looking at, we want to make sure that they can adjust culturally as well too. So have no fear. I want to say, I really feel like the hospital now in this post-pandemic period, we're about to do something new. And I think, there's a saying, it goes, the day that you plant the seed is not the day that you eat the fruit. And right now, I could see the heart, the passion of the minister. I think we have a very able champion at the helm of the ministry. And we are about to make some serious investment in our health system. The hospital is 60 years old this year. So naturally, the infrastructure is falling apart, the equipment is aging out, issues with the incinerator, all of that. We have a $130 million capital expenditure project that is about to be rolled out that will be addressing things like the incinerator issue that has been smoking out people in Bridgetown, much to my chagrin. And we are looking not for another incinerator necessarily, but if possible, we want to find a more environmentally sustainable option that won't be billowing smoke out, because we have to walk the talk. Our Prime Minister is a climate champion. We're making sure that the technology that we select will be one that is on par with what her messaging is. On top of that, you would have heard the minister make references to investment in new equipment. When you raise the point about the levy doesn't come to me. The levy is going to support the delivery of health care to the same people who are paying in, and some who can't. So when you heard about a new CT scan, it is the newest state-of-the-art CT. It is the only CT scan of its kind on the island, and we're about to get another one for the Accident and Emergency Department dedicated to A&E. It's going to allow us to also do work on complex cardiac cases that we've never been able to do before. We're hoping that all of these investments as well will be able to allow the hospital to generate revenue. So not just serve the public, but make some money to help to offset some of the costs. Maybe then we can look at rolling back the levy, maybe. Investments in the new MRI. Hospitals never had an MRI. We used to have to send patients out to private providers all the time. The investments are being made. The capital expenditure project as well, we're looking at building out a new lab, a new morgue, long-standing issues finally being dealt with. I don't want to be long just because we are heading into lunch, but I also want to make a very brief reference before closing to the investment that we're making in people. Many of you remember a few years ago when we had an issue with recruiting nurses because many of the nursing students were not able to pass the regional exam, and that had been addressed. But even so, we have an issue where we're getting an attrition of our nursing complement, and it's not a Barbados issue, it's a global issue. The board is actively looking at ways to improve the conditions for nurses, whatever it takes, because at the end of the day, nurses are at the bedrock of the health system. The doctors can write the treatment plans, but when we leave, it's the nurses there on the units, hour after hour, making sure that things happen. I personally am committed to making sure, as well as the minister, of course, with his lead, that we get a fair deal for our nurses. But we also have an issue where international recruiters have been on the ground. We can't pretend to be ignorant of these things. So while we are working on improving their conditions and creating posts for specialist nurses as well, we have other issues where we have people actively on the ground recruiting nurses. And there's serious pull factors because when some person is giving you a whole relocation package, housing, kids, education covered, everything, to be honest, who wouldn't say yes? So we are fully in understanding of where we are with that, and it's a priority area as well for the minister and his team. I wanted to also highlight the fact that a couple of programs that were put on pause during the COVID-19 pandemic have been restarted. The midwifery program, I believe, hadn't released anyone who completed that program since about 2019, 2020. And we have seen the restart of the midwifery program. Also the EMT program, the ambulance workers, that program was on pause, that has restarted. We've also been able to look into getting the nurses trained in phlebotomy. Phlebotomy is a big word that just means that nurses will be able to draw blood, put up IVs, and do some of these tasks that normally add to the additional cumbersome nature of a doctor's work. But on top of that, it means that if a doctor is not present on the unit, if there's an emergency, if there's someone who's acutely bleeding, a nurse now will be able to put up an IV, set up a bag, a fluid bag, until greater intervention can be taken. On top of that, I will say, I don't know if any other Caribbean territory has the number of specialist doctors that QEH has. Can't. Within the last year, we brought on another kidney transplant surgeon, a hepatobiliary surgeon, a neurologist who specializes in stroke medicine. State of the art. So I will say everything above A&E seems to be relatively okay. There are issues upstairs. I will admit to the fact that a couple of the operating theaters, we have to work on the air conditioning, and that is as well included in the capital expenditure project. Or maybe we can take it out of the health levy if that permits. But overall, the hospital is a good place. And it has a strong team, but I think the weakness is really the accident emergency experience. I'll share something with you yesterday. It's almost like people have PTSD, or maybe because you hear these horror stories all the time, they almost don't know what to expect when they go into the A&E. I got a call yesterday morning from a friend, a very, very close friend. Her mother had to go to the ER yesterday. So she's, oh my gosh, Crystal, I don't know how long this thing will take, but mommy XYZ. I said, darling, how long have you been there? You know what she told me? 10 minutes. And I am not lying on the Bible. She told me 10 minutes. I said, okay, well, a couple of things have to happen before, because she wanted me to try to expedite. You know, ultimately, I didn't have to. Her mother was on a bed by yesterday evening, on a ward. So there are periods when the A&E goes through what we call a surge. For some reason, it happens a lot around crop over. It happens at Christmas time. But for the most part, things are starting to stabilize. And when phase 3 of the A&E is fully rolled out, and we get some of the additional staff, and we're actively working on improving the flow issues, not just in the department, but hospital-wide, I'm sure people are going to start to see the improvements that they're looking for. But what I don't want us to leave this chamber feeling is that there's any lack of capacity or any lack of heart to deal with what people are facing. We are fully committed to seeing the hospital become a better place, and I fully support the amendments before the House. Thank you.
Senator Cummings. Senator Cameron, Dr. Rogers.
Thank you very much, Mr. President, for affording me this opportunity to speak for a few minutes. I will not delay lunch, but I rise to support this amendment in the return to the status quo. Prior to 2019, we would have been here in 2019 when we made this change. And I'm sure that some may want to ask the question, as I've heard this morning, so what has happened now? Why? But I wouldn't touch that as yet, sir. With your guidance, sir, your permission, I wish to just give a little preamble as a segue into my substantive point that I wish to make, seeing that so much has happened since I left. I leave the island for 2 weeks, and there are these seismic changes within the chamber, etc. I would like to attribute it to me, but I would like to say how much of a pleasure it is to be back here, sharing in these proceedings in the development of our country. And as I said, there have been some changes, and oh, what a difference a day makes. I wish to publicly, since I didn't get the opportunity to, thank the 2 senators who would have been here prior. That is Dr. Christina Hines and the Honorable Dr. Charleston Brathwaite, for their contributions over the time that they were here. I believe that Senator Brathwaite was very instrumental in bringing to the floor the focus on food security in Barbados, something that I believe that I would want to continue to highlight in this chamber. And Senator Hines was very instrumental in pushing, Dr. Hines, for pushing for child protection. And when that legislation, the child protection and child justice bills do come, I certainly will be consulting her. I haven't asked her yet, but for any input that she would want to make or have made in this chamber on her behalf due to her passion on it. I'd also like to welcome the Senator, Tricia Watson, in her absence, and extend my condolences to her on the passing of her dad, who gave yeoman's service to this country, and Senator Walters, who's here with us. I realize that the presence of Senator Walters has caused quite a buzz that we were not used to for some time in this chamber. So I look forward to the back and forth and the other things that will come as a result of it. Sir, I wish to acknowledge that today is Commonwealth Day, being observed throughout the world. I wish to ask God's guidance on the nations of the Commonwealth as we continue to work together for the betterment of our planet. And I'd also like to acknowledge, since I left prior to the start of the Lenten season, I wish all Christians a blessed and reflective Lenten season at this time as we go through our season of purgation. But I could not help but notice how things seem to mirror what is happening in the country at this time, because the Lenten season is very important, sir. Just if you would permit me to go into a little bit of geography, on the 21st of December, we would have observed the winter solstice, which is the longest and darkest day of the year. And then shortly after that, we celebrated in the church shortest and darkest day, longest period of darkness, the shortest day of the year. And then shortly after that, we would have observed our season of light when we gave thanks for the coming of light. And just as the days are getting longer on the outside, the Christian people are encouraged to acknowledge the light coming into the world. And then we move to the season of Epiphany, which is when the days are getting brighter and brighter, and the church calls us to become more illumined. It's a period of illumination. I know I'm not going to stay too long, man. This period of illumination, and then we go into Lent, the series of the period when the days are getting longer, and that's what the word Lent means. It's not really a spiritual word or anything. It just means the time when the days are getting longer. And we use it as a time of purgation in preparation for what we consider to be the highlight of the Christian year, which comes shortly after the spring equinox. And that is the time when the light overcomes the darkness in the world. And we celebrate Easter. And I was reflecting upon this, on the political things that have been emerging in the country, and I couldn't help but notice that the change came during the season of Epiphany, the season of enlightenment. The people who walked in darkness have seen a great light. That is the quote that is often used. And I suspect that if we were looking at it from the perspective of one group of people, it would be in anticipation of a great Easter at some point in time, when the light will overcome the darkness. But we can also look at it the other way, sir, that we are debating this bill during the season of purgation, the time when we're called to look deep within and repent. And repent really comes from the Greek metanoia, which means a change of mind. And it is good that, as I heard the honorable minister speak this morning, the reason he gave, why the reversal of the policy of 2019, he said it's just that the process now does not work efficiently. So there's been a metanoia moment for the government, and we congratulate them on the change of mind that they've had in bringing this particular bill to us at this time. So I applaud the minister for his repentance, and repentance there in the true sense of the word, metanoia. It's a good Roman, sir. But on a serious note, I've listened to all that has transpired here this morning. I just want us to remember that we are talking about the health of our people, and this is our principal tertiary health care institution. And there's nothing political about it when it comes to the health of our people. Because as I've said before in this chamber, I've said in other places, long before there were political parties, we were people never meant to be. When we get the opportunity to govern ourselves, we do what is necessary for the betterment of all. And so I wish to applaud the maturity of the government, thank you, for recognizing that we need to make the decisions necessary to make this institution the best it can possibly be. But that being said, as Senator Haynes so passionately articulated just now, let us not be beating people up. Let us just give thanks for what good work would have been done over the period of time, and thank the past executive chairman for her stewardship of the institution. It is not an easy institution to run. It will never be, as long as we continue the type of health care policies that we have in the country. It is the envy of many, but recognize that it comes at a great price, and it will never, ever be easy to manage this institution. But we thank those who have given their time and their effort, and here I wish to highlight something and to join with Senator Maynard in saying that we need to look at how we compensate our nurses. I've often said that, strangely, he chose teaching as well, because nursing and teaching are what I call two quasi-vocational type jobs, where you cannot really pay a teacher for what he or she does when the teacher really puts his or her all into it. And the same thing is true for nursing. But at the same time, these people still have to shop at the same supermarkets that everybody else is called to shop at, and sometimes the prices are not set for their salary levels. And so we have to look at how we can better compensate them for the human service they give to us. I believe that some, perhaps on the outside, would be saying that this is an I told you so moment, because the problem that was perceived in 2019, though the minister this morning pointed out that there's been a long call for greater autonomy. The problem that was perceived by some, I believe, was more of centralization of the management of the QEH in one and the same person. And that is always dangerous, but as I said, the executive chairman did her best. And it would always been a challenge, because as I reflected on it, I remember the calypso by the Mighty Spoiler. The Mighty Spoiler had a calypso about a magistrate who was going to court one morning and was stopped by the police. And the police charged him for speeding. And when the case came up, it so happened that the same magistrate was to preside over his case. And he decided not to have any legal representation, he represented himself. So when the officer got up and accused the driver of speeding, the officer said the driver was speeding, and then himself told himself the officer is lying. And then himself told himself, listen, this is no sport. Then himself charged himself with contempt of court. And that is precisely what could have happened here with this executive chairman position. So I'm very happy that we have made the change. But what I want to speak to in this legislation is something that the Minister of Health and the Honorable Senator, well, the most Honorable Senator would have spoken to this morning. He said, years ago, when he made a suggestion about the composition of the board, he had included the Barbados Christian Council. And as I look through the list in the first schedule, subsection C, I do not see any representation here from any pastoral representation. Neither, I'm hearing on the side that I took them off. And there's only one person here who can take them off. That's what I heard. Right. I see no pastoral representation, neither do I see anyone specialized in psychology. And this is not to say that the persons on the board do not have the requisite skills, but just recognize that when we're dealing with professionals and people at the top of their level, the more and more we study, the more focused we become in a particular field. And sometimes when we make decisions, it may not be able to take into account something that needs to be focused on elsewhere. And I believe in the post-pandemic QEH, which Senator Haynes pointed out, the post-pandemic hospital is about to do something new, so she has in mind an Easter event as well, sir. Well, that's what we're supposed to do, sir. In a post-pandemic QEH, in the post-pandemic world, one of the key things that we've seen coming out of the pandemic has been, how should care be apportioned? Who should receive care? And Senator Haynes just pointed out the triage system that is in the A&E and I believe in ICU at the hospital. But I just want to quote from two articles, if I'm permitted to do so. An article by Dr. Kathleen Liddell from Cambridge in 2020, Who Gets the Ventilator? Important Legal Rights in a Pandemic. And it's a little long, but if you permit me. At some point during this pandemic or the next, all countries will need to answer hard questions about whether and when scarce ICU resources such as ventilators, beds, and staff should be either withheld or withdrawn from certain groups of patients solely for the purpose of providing them to others. I'm just in the post question. Attempts to answer these questions can be found in a wide range of ICU protocols and ethical guidance documents, many of which embrace the foundational principle of save the most lives. Unfortunately, this worthwhile goal has generated many suggestions that could violate the law. I've highlighted that to make the point, sir, that there will come a time when the decision of triaging will have to be removed from the person on the spot there to the board in some cases. And the reason why I'm raising this is because of another article I've read by Max Feinstein and others in 2020. Considerations for ventilator triage during the COVID-19 panic. And his thing is, the separation of clinical care from the triage decision making is recommended in pandemic triage protocols. This approach is important because resource allocation and the ethics of face-to-face patient care have the potential to be at odds in individual cases. Furthermore, this separation might help to reduce the moral distress experienced by healthcare providers in the event that patients are excluded from receiving scarce resources. I am highlighting this, sir, because as we go forward, these issues will present themselves, and more critical issues will present themselves, and there will come a time when that responsibility has to be placed to the board. And it will be important for the board to have someone there with pastoral skills, because just as these healthcare workers are going to have challenges, ethical challenges in terms of who gets what, the board will have those ethical challenges. And there will be the need for someone there who can offer a pastoral avenue in how we go about making this decision. There needs to be someone there who can make it a psychological input into how we go about making decisions. They may be in one and the same person, but I'm just suggesting that the board be expanded to include that pastoral element, and not a chaplain, but someone who is there as a part of the decision-making process. That is basically my contribution to this. As I said, I support the going back to an executive officer, chief executive officer, and I commend the government's maturity in recognizing the importance of making this move at this time, sir. Thank you.
Thank you very much, Senator Cannon, Dr. Roberts. Senator Cummings.
Thank you very much, Mr. President. I beg to move the suspension of this chamber for the lunch period, and I beg to move that this Senate be suspended until 3 p.m.
The question is that this sitting be suspended until 3 p.m. today. The Lord Honorable Senators in favor, please say aye. Aye. Those against, please say no. You think the ayes have it? This sitting is suspended until 3 p.m. today.